Assalamu alaikum. I am Dr. Jahidul Khan, working as cancer specialist and surgeon, Department of Surgery, Boshundar Addin Medical College Hospital, South Karingons, Dhaka. And now I am presenting my thesis topic. The title was the comparison of conventional versus stationary stable technique of lymph node assessment in radical gastrectomy. It was a prospective comparative study. The background was the gastric cancer remains a significant global health concern, ranking as fifth most common cancer and fifth leading cancer related deaths worldwide. So each year, 1 million of new cases are diagnosed around the world, thus representing a public health issue. So calculations and predictions indicate that the incidence will rise significantly by 2035, posing significant and particular challenges to the health systems. Before receiving surgical interventions or at the time of their first diagnosis, more than half of the patients with stomach cancer has metastasis to the lymph nodes. So, the optimal extent of the lymph node dissection in gastric cancer surgery is essential for the better management of those gastric cancer patients. The success of radical gastrectomy is significantly influenced by the surgical procedures of gastric resections of gas and the concomitant dissection of the lymph nodes, as well as it helps to lowering the recurrence after surgery. We hypothesized that harvesting of the lymph nodes by a technique that is stationary retrieval technique would be the more efficient and provide better quantity of lymph nodes than we do that conventional technique. Rationale of this study was the retrieval of lymph node after a gastrectomy is critical for proper staging, and therefore proper management and outcome, a perfect lymph node evaluation and retrieval is required for the good prognosis and disease-free survival of the patient. It is suggested that at least 16 lymph nodes should be examined pathologically. However, if possible, more than 30 lymph nodes should be removed for evaluation. In conventional technique, we face that the problem we usually found inadequate number of lymph nodes, that is less than 16 or below the 10 or below 8 in conventional technique. So we were compared the technique with our newly adapted stationary retrieval technique to see any association between the numbers of harvested lymph node during radical gastrectomy. So far, our best of knowledge, no such type of study has been performed in Bangladesh up to date. In this study, we has been able to show whether this station-wise retrieval technique is superior from the conventional technique in terms of the efficacy and quantity of number of lymph nodes. This study has also helped in proper staging and management of the patient, as well as they standardized the D2 technique of lymph node dissection in Bangladesh context. This study was conducted in Department of Surgical Oncology, NICRH, and this was a prospective comparative study, and the duration was about 1.5 years. And the sample was collected by purposive sampling technique, and there were 70 patients allocated in 2 arms, and 35 patients in conventional arm, and 35 patients in stationary retrieval technique arm. And all the patients diagnosed with carcinoma stomach undergoing the Q2 resection with D2 lymphadenectomy was included in this study, and those patients are not unwilling for surgery and unfit and metastatic or recurrent, or other than the adenocarcinoma, patients are not included. And examiners for harvesting lymph nodes were qualified based on their experience. Based on the surgeon's preference, lymph node dissection was performed by either 2 techniques, that is conventional stationary retrieval technique, and 1 technique that was conventional. In conventional technique, we, after gastrectomy specimen, along with the omental tissue, the picture shown that the omental tissue of lymph nodes attached to the specimen will be sent immediately after surgery. The whole of the specimen is sent. Then in stationary retrieval technique, we adapted a pill box that was labeled by station number according to the Japanese gastric cancer classification, that is station 1, 2, 3, 4, according to classification. The pill box was prepared, then stationary retrieval technique started during surgery and after the surgery in operating theater, where surgeons from the specimens identified and collected the lymph nodes in a box according to the Japanese gastric classification. During operation, the examiner harvested the stations level 7, 8, 9, 10, 11, 12 that is classified according to Japanese gastric classification, we will show later, and picked from the operating field and transferred the harvested lymph node to the dedicated box. After successful extraction of the specimen, the bacterial literature was utilized that was identification of according to perigastric lymph node 1, 2, 3, 4 and 6 number of lymph nodes were separated from the specimen by bacterial technique, and those separated lymph nodes collected in the box and then transferred those lymph nodes to the dedicated histopathology department. And this is the perioperative picture where after removal of the stomach and omental tissue, then station number the 7, 8, 9 and 12. And those stations were removed adequately and efficiently by after the hepatic pedicle, common hepatic artery, splenic artery and celiac axis. Those lymph nodes are removed. And then the submitted box marking the station level submitted to the pathology department, and patient was advised the follow-up after the surgery with histopathology report at the surgery OPD with direct telephonic contact if required. All data was preserved in hard copy and soft copy also, and investigated by the principal investigator. And this is the histopathology report. Here, this is the special report that omental tissue and specific the 7, 8, 9, 12 number lymph node was collected separately. That is the 14 plus 7, around 21 lymph nodes was collected, and there 13 lymph nodes was metastatic. This is another report where total 26 number of lymph nodes were collected and metastatic lymph node was 16. The primary outcomes were number of lymph nodes in this study, and secondary outcome was the number of metastatic lymph node, postoperative complication, and the influence of demographic and other clinical factors on the lymph node detectable efficacy. And this is the Japanese gastric classification. N1 notes that the perigastric lymph nodes, I was previously said the number 1 to 6. Number 1, 2, 3, 4 that around the stomach, and number 7 is station, that is trunk of the left gastric artery. Number 8, common hepatic artery. Number 9, the celiac trunk. And number 10, there is splenic hilum, it is not removed usually. And number 12, that is common hepatic artery proper, that is hepatoduodenal ligament. So, and then this is the, according to Japanese gastric classification, this picture was shown. And in TRG, the total radical gastrectomy, we remove the D2 decision all the lymph node up to 12A. And in case of upper radical gastrectomy, 12A is not removed. In case of lower radical gastrectomy, and my study, this technique, the stationary table technique, yield median lymph nodes of 17, interquartile range of 15 to 22, and conventional technique, that is the median lymph node count is 10, that is below the 16. And there are other study, they conducted such type of study where the lymph node count was 39, and this is a study working in the China, the University of Nankai, People's Republic of China, and there shows also the large number of lymph nodes. The conclusion is